Hello, everybody. Welcome to our podcast. It's a great honor to have with us today Dr. M. Unnikrishnan, a distinguished vascular surgeon and the head of Department of Vascular and Endovascular Surgery at Sri Uttradham Tirunal Hospital in Pattam, Tiruvananthapuram. With an impressive clinical career spanning over 37 years, Dr. Unnikrishnan is recognized for his unparalleled expertise in the field of vascular surgery. His commitment to advancing medical education and practice is underscored by the Dr. B.C. Roy National Award in the category of Eminent Medical Teacher, which he received in 2016. Dr. Unnikrishnan has also served as the President of Vascular Society of India from 2019 to 2021. Currently, he holds the esteemed positions of Special Invitee of Board of Vascular Surgery at NMC and National Board of Examination and member of Task Force at the World Federation of Vascular Societies. Today, we have the privilege of delving into the wealth of knowledge that Dr. Unnikrishnan brings to the realm of vascular surgery. His dedication to advancing the field and his remarkable career make him an invaluable guest. Welcome, Dr. Unnikrishnan. It's a pleasure to have you on our podcast.
Thank you very much, Harpita. That's been a wonderful invitation. Of course, I've been in the field of vascular surgery for almost like 3.5 decades or more and continuing in a smaller scale. So today, I have many topics that I can share. I thought we will talk about peripheral vascular disease. Peripheral vascular disease, if we say, that connotes the pure blood vessel circulation into the legs. So that is what I am going to talk about. And this is part of atherosclerosis, which means basically the deposition of lipids and cholesterol as the person increases his age, 55, 65, 70, the accumulation gets more because of several reasons I'll be alluding shortly. So that is generally told as a generalized disease. It occurs all over the body with what is known as a segmental predilection. That means at the origins and bifurcation of arteries originating from the aorta, Mahadhamini we call it in Hindi as well as in Malayalam and Sanskrit. That's a major blood vessel, big channel, which takes and brings pure blood to the entire body. So those vessels to a particular organ where they start off from aorta, that is vulnerable with this deposition. And when they bifurcate and divide into smaller, especially the proximal, that is the earlier kind of, not till the blood vessel reaches the cells, but it is like first 1 or 2 centimeters. So that is atherosclerosis. That is the principal cause of peripheral arterial disease, like many other, like coronary artery disease, like stroke, which comes in our some elderly patients, then the kidney failure, then the blood vessels supplying to the intestine. So anywhere there is a pure blood supplying required, and that is now diseased with this deposition of cholesterol. It can lead to dysfunction, and when it is totally occluded, it can lead to severe problems with that particular organ, which is the artery supply. So today, as I again said, it will be on the peripheral arterial disease, and I'll go straight to the I am putting it little crudely in the sense. So our idea is to keep blood circulation improved or revascularized. That means we make keyhole surgery or open surgery so that we increase the blood supply, which is decreased to various extents, including a total cutoff. So that is what is what we are meaning by prevention of amputation, so that the person can walk on his feet, which is very important in anybody's life. Now, first I will go to the basics. Risk factors are male gender and age above 60 years. And if you come to the other risk factors, smoking is going to give a lot of trouble for this process of atherosclerosis, alcohol consumption, diabetes, you know that the metabolic disease, hypertension, it vitiates any disease into 5 to 10 times, obesity and hypercholesteremia, as I mentioned, the lipid level, and then of course very important factor is the physical inactivity. So these are all the points which creates more of atherosclerotic fat deposition and the peripheral arterial disease, which is the topic for the day. Now, the risk behavior is tobacco use and alcohol abuse. Risk factors I've already mentioned, and the two non-modifiable risk factors, male gender, age above 60 years. Having said that, in ladies, the estrogen hormone, for a long time in their life, it protects. So that is why male gender is an important non-modifiable risk factor. Now, the atherosclerosis is the cause more than 90%, but there are non-atherosclerotic disease as well as called arthritis. Then arthritis again is divided into temporal, giant cell, Takayasu, and Burgess. Burgess used to be common earlier in our country, but it is much less these days. Non-arthritis, there are a few like post-operative, post-irradiation, traumatic, iatrogenic. These are the other causes. Now this picture shows on your right is the entire arterial system marked in the red, and on your left two pictures the aorta and various branches to the brain, the heart itself, the kidneys, the lower limbs, intestines, etc. Now, the atherosclerotic plaque, which is the underlying basis for all problems in about pure blood circulation, on your left you find is a big amount of that yellowish material told as lipids, a lot of the inflammatory response, and a very small fibrous cap. In contradistinction to on the right side, you find there's a lot of fibrosis, very few inflammatory cells, and very thick fibrous cap, which is a stable plaque. Now, when you come to the left side, this vulnerable plaque can get into hemorrhage inside, can ulcerate and produce embolism, and it can rupture so that the involved organ, there will be an acute or sudden stoppage of blood flow, and which can be a disastrous point. Now this again showing the normal lumen or the inner side of the vessel, and where the fat deposition is reducing the lumen for blood circulation. Now when you come to the clinical presentation of peripheral artery disease, first and foremost is an acute lower limb ischemia. This happens all of a sudden like lightning when a blood clot or an infected material or atherosclerotic plaque starts from the heart or aorta and gets into the legs. This can produce like a lightning. The patient has excruciating pain. It will be pallor will be there. He will not be able to stand or walk, and this is an emergency, and we have to manage this immediately by an operation known as the embolectomy. And then of course the rest of the four five things is intermittent claudication. They are not able to walk the same distance they used to, like 3-4 kilometers. When they get to about half 1 kilometer, they get the cramps and they have to stop. It progresses, if untreated, onto the critical limb ischemia, which can be called as an acute and chronic worsening. Then there will be like a trash foot or a toe gangrene because of the death of cells at the toe tips. And then we have ultimately when the foot becomes totally non-viable, meaning thereby patient is not able to stand on it, cannot work. This becomes a very severe problem. At this stage, I think unless we expeditiously treat the circulation, the patient may even lose the limb. Now, in clinical examination of history, how it has come, is it sudden, if it's slow, where is the cramp, and all those history and his risk factors, whatever he has. Then of course the examination of the pulses, how the limb is, how the foot is, what is the sensation like, Is it cold or warm? Is the foot a patient able to move and walk? All those points are very important. Then, of course, physical examination can give some clue. And then there is what is known as angle brachial index. That is the proportion of blood pressure in the upper arm and the lower limbs. So that will give us how much blood flow is reduced to the limbs. Then, of course, the sophisticated investigations like duplex scan, transcranial Doppler, that is to the brain, of course. Then, of course, we have to depend on contrast enhanced CT scan so that we can see where the artery is blocked and what is the distal tree like, whether any compromise is there. And then, of course, what kind of treatment is required. Is it risk factor control? Is it medical management? Is it keyhole surgery? Or is it endovascular surgery? Or is it open surgery? Now, what we have to do is, most important thing is that they have to, all this smoking, alcohol consumption should be stopped, particularly smoking. And control of diabetes and hypertension is mandatory because it vitiates the atherosclerotic process much more. Then, of course, a diet discipline is required. Some amount of physical activity within capability of the patient it is required. In normal people, normal subjects also, they have to be physically active so that they can prevent the progression of atherosclerosis and control it to a great extent. Now, in management, I already mentioned this, medications are important, blood thinners, statins, and then, of course, if they are not helping, there will be angioplasty stenting, we have heard of, in the heart, in the carotids, in the lower limb arteries. Then in the lower limb arteries, sometimes it can go for aneurysm formation, which can be treated open repair or endovascular repair. Then, of course, open surgery in the way of endarterectomy or long bypasses, which is required from normal area to the diseased area. Now, the medications are antiplatelets. That means the platelets should not get congregated and they will not form an emboli and producing disease. Statins are to reduce the lipids and the cholesterol level. Celestosol is the phosphodiesterase inhibitor. Pentoxifillin improves the hemorrheology of the RBC, so improving the blood circulation. Then in the intervention of endovascular surgery, we have percutaneous balloon angioplasty. I'll be giving some examples. Then, of course, stenting whenever is required due to indication. Then bypass surgery is a traditional, conventional treatment, and hybrid is you can combine angioplasty stenting with the bypass surgery so that the patient gets the benefit, and we don't go for a massive surgery. We can get the best of endovascular and open surgery. I'll give you some examples. A 60-year-old male patient came to us. He did not have any history of diabetes or hypertension. He was a smoker, he was obese, lower limb, no pulses were felt. It was cold and blue, intractable pain for 1.5 months, an ulcer in the great toe, and he could not sleep with pain or ischemic pain. And that is the picture. He came on a wheelchair, his foot was bluish, he could not put his foot down. And in fact, I was equally concerned. It looked like he may lose the foot. But then we kept him on some medications and did the CT scan. You can see that on the right side, the aorta goes into the lower limb with all the vessels, whereas the iliac artery, after the aortic bifurcation, is occluded for a distance. And again, at the knee level, the artery is also occluded, so that it's got what we call multi-level block or, two blocks, so that, the blood supply is come down to very severely ischemic level. So we have done an artificial graft to the aorta that is being sutured after laparotomy. Then that is the particle which is removed. And then we have brought that artificial graft to the groin. You can see that it is come into almost at the upper part of the thigh. And he is now improved. His angle brachial index is 0.7. He's able to walk 1 or 2 kilometers doing his work. And most importantly, he is 3-4 years later, he is very happy and pain-free, and is able to walk. This is an area where open surgery is not required, but endovascular stenting can be done. The red arrow shows this severe narrowing to about 80%, 85%. And we dilate that with a balloon and put a stent so that the metal part keeps the artery open fully, and this patient has done well. Now another patient, I think the 64-year-old patient, he came in the night with intractable pain in the right lower limb, and starting from 1 p.m. onwards. And in fact, in here there was history that he had twice. In fact, she had twice fracture of the femur, and the doctors tried to fix it. You can see that the multiple kind of the screws and plates are done. The superficial femoral artery got blocked, and she came with severe pain and not able to move and walk. And so we did a duplex scan, showed femoral artery, the leg artery mid-thigh, it is blocked, and the contrast angiogram showed again total cutoff of the artery. Surgery involved thrombectomy, that means removing the clot, and femoropopliteal bypass. That's what we did, femoropopliteal bypass using his own vein. You can see that artery, there's no blood coming, it is totally blocked. That is the femoral vein graft coming to the popliteal artery. That much clot has been removed from below the knee, and then this lady could walk nicely. There's no problem at all. That's a Doppler post-operative. Now, there's another patient, 86-year-old patient. He has been having hypertension. He had a pacemaker earlier, and he developed again sudden excruciating pain, took injections and tablets, presented to me in our institute, SUT, 36 hours later, and then we found it was pulseless. He didn't have pain while resting, but he could not support his weight, he could not walk. Duplex scan and the CT angiogram showed thrombus in the leg, and that you can see that there's a cutoff where the green arrow shows, and then you can see that such a big clot from groin to mid-leg we removed with a keyhole operation we did in the groin, and now it's about 1.5 years. He's doing well. This patient would have definitely lost his limb if we had not done this Fogarty embolectomy. There's another patient example, is a 57-year-old man. His diabetes was not controlled. He was a smoker as well, and he didn't have pulses. And we 2 weeks of medical treatment, he did not improve. Duplex scan and CT scan were done. You can see that this shows not so much degree of thing, but his pulsations were absent. And then we have done a stenting there, and he is reinstated his perfusion in the lower limbs, and he is happy man. Now there's another patient, 78-year-old man, intractable pain in the foot and great toe, a known case of carcinoma prostate. He had bony metastasis, but he could not sleep. He had continuous pain. We had to do something for him. That you can see that great toe is bluish, and he has intractable pain. You can see that it's the lower leg where the knee area, just above the knee area, there's a total cutoff, and that is the angioplasty done by my colleague. It's opened up the vessel, and he is doing well. Another example is a 58-year-old man, again with intractable pain. He has been a smoker, no pulsations at all, felt in the limb. You can see that there's a discontinuity, just lower abdomen. Both internal, external iliac arteries are occluded. The distal vessels are fine, and he underwent Aetio-bifemoral graft procedure, and I think he is doing quite well. I've seen him about 6 months back. This is coming to the profundoplasty into the groin. Post-operative, he is doing well. And another example is a 65-year-old man, is a retired engineer. He had difficulty. He came in on a wheelchair. Some color changes were there, and he could not sleep well. And it was the angle brachial index, instead of 1:1, it is 0.35 in both bilateral. And that is the CT scan shown. You can see that what we call task D on the left side, task C on the right side. What we did was thoracic Aetio-bifemoral graft. We got the blood siphon from the chest and got into both the leg arteries, and he is doing well now. He is on follow-up. I think to summarize, the peripheral artery disease, although it starts with some simple symptoms and often misdiagnosed, it progresses to form threatening to the limb circulation. And as we all know, patient who cannot walk, who cannot go to a place, who cannot do his routines, I think is bound home and without a limb, life is very difficult. And that is what peripheral artery disease treatment has helped us. Majority of the patients, 95, 96 or above, patients have improved when we have done appropriate treatment, and it is very gratifying to see the patient from time to time. Now, this is the patient who has got good collaterals. You don't have to do anything, only graded exercises, walking, and medication. And you can see here also a lot of collateral vessels, small vessels, enough blood comes. And in non-reconstructive, where we cannot operate or do keyhole, we have two drugs. One is prostaglandin E infusion for 5 days in every month, and stem cell therapy to regenerate small blood vessels to improve the blood circulation. We have it in Kerala, Vascular Society of Kerala initiative, that is to reduce the amputation. We cannot make it amputation free totally, but we can reduce the amputation rate by appropriate treatment using the best of vascular modalities. And it is the best to go to a vascular surgeon to get not only his peripheral artery disease, anything like stroke prevention, kidney safeguarding, bowels, and all kinds of vessels. There will be now impure blood vessels also involved. I have only talked about pure blood vessels. This was inaugurated by our state governor, and on the vascular day, 6th of August, we've had 28 centers all across the world with the slogan Amputation Free India. And I was lucky to propagate this walk a mile to live with a smile. If a person can walk a mile, I think his life will be secure, his health is good status as well. So the peripheral artery disease prevention and treatment has a great impact, not only in that human being, but on his family also. So thank you very much for your patient hearing. Thank you. Thank you, Arpita.
So, doctor, I would like you to answer a couple of questions. So, in your clinical experience, what are some of the most effective non-invasive interventions for managing the symptoms of peripheral artery disease?
I think like in vascular surgery, the risk factor control, avoiding alcohol and smoking, and treating diabetes and hypertension, this risk factor, and then having a appropriate diet, not overeating, because at 45-50-year-old man need not, his growth is completed, so he needs to take only minimum amount of food, and then he should have some physical activity like 8 to 10 minutes at least 5 times a week. That can really prevent. Then without operation, we have specific medications like ecosprin. Maybe we can add clopidogrel, dual antiplatelets. We can have stilose or pletose, as I said, phosphodiesterase inhibitor, then pentoxifillin. Then we have the graded exercise itself is a treatment. Then if those things don't work, and if the patient comes very late with severe threatening symptoms, we have this keyhole procedures. Keyhole procedures using a tube with a balloon attached. We can open that critical area which is stenosed so that blood flow is started. We will push supposing there's 90% lumen, that is the inner pathway is obstructed, we can use a balloon and reallocate this cholesterol back and forth, so that this is like removing the ice in the we don't have much ice in our part of the country except in Kashmir, but in Western countries, many times the ice blocks the entry of the house, so they just take it out and then the road is open. Similarly, they can push with the balloon, and if that doesn't work or if there's a complication, we can put a metal stent. It's an alloy. Nitinol is the alloy. It can be put so that it will keep the pathway open. So, and then if these are the stenting, balloon angioplasty with stenting, it's a keyhole procedure. It's not a massive, there's no big wound, not much pain, and 2-3 days patients can go home. Then the other situation is when these treatments are not possible, like stenting or open surgery. Then we have 2 options medically again, prostaglandin infusion and stem cell treatment. This is all salvage procedures, and where the limb is being threatened, that it has to be removed. That stage only we will try this when there is no what is known as a distal runoff.
Yeah, and doctor, from a procedural standpoint, what criteria do you
Yeah,
consider when determining if a patient with PAD is a suitable candidate for minimally invasive
yeah,
interventions like angioplasty
yeah,
or stent placement?
yeah. I think a good question you have asked. See, when, say, for example, if I take, since we are talking about peripheral artery disease, if it is in the femoral artery, that is, femoral artery is, it starts from just below the groin to about 2-3 inches above the knee joint, such a long artery. It's like a national highway going to the leg. There, if it is, say, around 10 to 15 centimeter long, tight stenosis or occlusion, we can do stenting or balloon angioplasty. Then, but if it is more than that, the result will not be that good. Number one, result will not be everlasting. So generally it is 10 to 15. Now there are techniques, subintimal angioplasty, and then better stents. But the stents, see what we are doing is we are just pushing the cholesterol back and forth, and over and above, if you are putting stent, means it's a metal or an alloy that in a 5-6 millimeter blood vessel, if you put that itself, it will call for some like for example reaction, what is known as fibrointimal hyperplasia. So that in operation, what we do from normal area to normal area downstream, we put a bypass, either using a vein or using a prosthetic graft. So that will have a much more durable, that means it will last much, much longer, 5, 10, 15 years or even 20 years.
And doctor, how do we assess and manage the potential complications associated with PAD, such as wounds, infections, and ischemic events?
Yeah. See, one thing important is the infection is an enemy not only for the patient but for the surgeon as well. Because if there's infection, it is going to upset the whole procedure. If the graft or a bypass is there, that can occlude, that can get infected. So what we do is the infection has to be treated to maximum level by doing a culture, finding out what is the bacteria, virus or fungus, treat it sufficiently with local antibiotic and medication until you find that the leg is clean, there may be an eschar, there is no purulent discharge. At that point only we can do the procedure. In the form of big sepsis, it is better to delay, treat for some time, then improve the, select for the stenting. That applies to the open surgery as well.
Thank you, Dr. Unnikrishnan. Now, as we conclude this session, I really want to thank you for sharing your invaluable insights. We truly appreciate your presence. Thank you so much for joining.
Thank you.
And to our esteemed audience, we also want to express our gratitude for joining us today. Before we say goodbye, I encourage you to explore our MedSynapse platform. It offers a unique opportunity to engage in enriching discussions, connect with esteemed medical professionals, and contribute to the progress of healthcare. Until we meet again, take care and keep advancing in your medical journey. I'm your host, Dr. Harshita,
Thank you.
signing off. Goodbye.